Okay, so red flags to shocks. So hemodynamics, we've kind of been touching base on a few of those, right? A few hemodynamics we've been talking about were like our CVP, our PA pressures, right? So we want to make sure we are identifying what might be causing a rise in our, let's say, CVP. What's causing a drop in our blood pressure, right? So we got blood pressure. Which blood pressure do we use? Systolic, diastolic, PA, systolic, PA, diastolic, CVP, PA pressure. Which one is the best? Is usually our MAP, right? So MAP 65 is usually what we're going to be looking at to assess if someone is, getting into trouble, right? MAP's less than 65. That means that the MAP in the, the arterial system, the aortic root is going to be much, much less, right? And we're worried about the brain blood flow, right? We're worried about kidney blood flow. All these things are going to reduce flow to the organs, and that can lead to, worsening shock states. And again, another thing to caveat is a 40-point drop in someone's baseline, right? You look at their trend, you just say, hey, they were, 160s, 170s, 140s, 150s, and now they're like 100 to 110. It's like, what the heck? Why are they 100, 110 today? Is their blood pressure under excellent control? Or like, did they start a new BP med? Or is it just their sepsis process getting worse, for instance, right? And then tachycardia, that's a normal response, right, to our SNS. And we can calculate what's called a shock index, and that tells us how shocky someone is. So if the blood pressure is really, really low, that's going to be a higher shock index, right? Let's just make an easy heart rate of 100, right? Because technically that's tachycardia, right? So we have 100 over systolic of 100, right? That's a shock index of 1. Usually greater than 1 or greater than 0.9 is concerning, right? Now let's, so that's 100 systolic, 100 heart rate, 100 systolic blood pressure, right? Now let's change this systolic blood pressure to, let's say, not 10, that's too low. Let's make it 50, right? Now my systolic blood pressure is 50. Is that good? No. Obviously we don't have to calculate our shock index in that scenario, but we can see that the shock index went up. So you can imagine a heart rate of 140 and a systolic blood pressure of 110. That's a really bad shock index in of itself, right? So that shock index can really kind of gauge whether we, therapies, and also can tell us how sick someone is, right? Usually you might have someone ask you what's the shock index before they intubate them, and they like to have the blood pressure a little bit higher before they intubate because they know they're a high risk of decompensation when the shock index is high, right? And then bradycardias. So bradycardias are red flags when you have someone in shock, right? Obviously, yeah, it could be neurogenic shock, but that's pretty rare for that to all of a sudden pop up on you. It's like, oh, shoot, they got a T5 injury. So, man, you're a really excellent bed bath giver, right? So, no, that's probably, that's usually they will present with this, or they'll be like post-op spine surgery or something. But if they have bradycardia, you have a low heart rate, right? So, yes, heart rate and stroke volume is what makes up our cardiac output, right? Heart rate times stroke volume. But you can only increase stroke volume to a certain point. The rest of it is related to your heart rate, right? So your heart rate's 45, sure, you can have whatever stroke volume you have might be able to compensate. But the heart rate goes to like 30, you can no longer compensate, right? That is really what is driving the whole equation, right? The whole equation is multiplied by each other. So if my stroke volume is, let's say 100 cc's, that's a great stroke volume. And then now I have a heart rate of 60. That's okay. I can do that 60 times 100, that's 6 liters, right? Now heart rate's 30. Now I've gone from 6 liters to 3 liters, right? 30 times 100. So you can see the heart rate is a pretty static variable that you don't want to get too low. Okay, and we know with too high of a heart rate, then we start getting low filling. But our body will try to compensate by raising the heart rate to hopefully improve our cardiac output, right? So heart rate will try to compensate with SNS activity. Over here with increased firing to try to raise blood pressure. Not only will it vasoconstrict and increase, hopefully raise the blood pressure, but also it's going to try to fix this cardiac output equation. It's going to try to raise the heart rate because it knows the stroke volume is pretty much fixed, right? If someone's hypovolemic, for instance, you can't really increase the volume all of a sudden. We can release hormones, norepi, vasopressin, the RAS system, to try to hold on as much fluid as possible. But until we supplement that, with medical therapy, we might have a fixed preload. And now if the heart rate starts coming down and down, the heart rate starts coming down from 60 to 45 to 35, now that's a red flag, right? Especially if your heart rate was this really fast, and all of a sudden becomes bradycardic. That's a red flag puckering incident right there. All right, that's a situation where you're really, really concerned. Especially if you have like really, really fast heart rate, and then you have this slowing down all of a sudden. That's also a heart that's really getting affected by an acidosis or a low blood pressure, low flow to its right coronary artery, right? And you start getting bradycardia situation happening. All right, so then low urine output is another red flag, right? You're just carrying along and you have a Foley in place, all right, it's been working great. It's like, 200 cc's an hour, then it's 100 cc's an hour, then it's 30 cc's an hour. That's a drop in your urine output, right? And that is concerning. Oftentimes you can hear them, well, let's try flushing it. It's been in place the whole time. Why am I going to flush it, right? But you go through the motions. So I flushed it, and it's still 30 cc's an hour, right? But so less than no urine output in 6 hours, right? That is a red flag. Also less than 0.5 mLs per kilo per hour. So we used to always hear 30 mLs per hour is what you want, but that's when everybody weighed 60 kilos. Not everybody weighs 60 kilos in America anymore, right? So if you're 60 kilos, 0.5 per kilo is 30, right? That's half of it. So yeah, if they weigh 60 kilos, you can go by 30. If they got 30 cc's an hour, perfect. But if they weigh 100 kilos, how many mLs per hour should they be putting out? No, a little bit less than that, 50, right? 100 times 0.5 is 50, right? So 50 mLs an hour for a 100 kilo patient is good, right? So as long as more than 50 mLs an hour, that's great. So we usually the take-home point is it's usually 0.5 per kilo. That's what you're looking at. If they got less than 0.5 per kilo, that's a problem. Okay, and this kind of plays into what's called the rifle criteria. And we'll talk about this more in acute kidney injury and renal. But you can kind of guess if urine output is less than 0.5 for 6 hours, that's a problem. They're a risk for acute kidney injury. And the I in rifle is injury. That means they have injured the kidneys when you're less than 0.5 per hour for 12 hours. Right? That's a whole shift went by, and my urine output was only, let's say, you can calculate how much it is per 12 hours. It's 50 cc's times 12, right? But I only got 400 cc's, and they're 100 kilos in 12 hours. That's a problem, right? They should be getting 50 cc's per hour, right? That'd be about 600 cc's in the whole 12 hours, how much I should be getting, right? And then we have failure. That's where you are anuric, right, for 12 hours completely. Got no urine output the whole shift. Well, why didn't you let me know it's 6 hours in? Because 6 hours in of no urine output is a problem in of itself, right? But no urine output for 12 hours, I got less than 0.3 per kilo. We're really even lowering our threshold. That's going to be a situation where we're at risk for failure, right? So not only are we just like having acute kidney injury, that there's different levels of a creatinine of like 1.5 versus a creatinine of 4. There's the creatinine of 4 is much worse, right? And we'll talk about creatinines more with renal, but creatinine should not change, right? When you're in the hospital setting, they should not really be changing that much. There are situations where you might dilute it out with volume, like when they come to the ER, but once they are stabilized, their creatinine does not change. Creatinine is a function of muscle mass, right? You're not going to have a huge change of muscle mass overnight, right? It's a waste product of muscles. So if I have a lot more muscles, I'm going to waste a lot more creatinine. Baseline creatinine like 1.2. If I have an old frail grandma, my creatinine might be 0.4. Right? But if grandma's creatinine goes from 0.4 to 1.2 overnight, that wasn't because she just bulked up and she was doing deadlifts at the bedside, right? That means that she's not getting rid of this waste product. The creatinine is building up in her system because she's not excreting it. Okay, so you look at the doubling of the creatinine. It goes from 1.5x to 2x to 3x change in creatinine. That is considered a really bad situation or a red flag for someone that's going into renal failure. And why is that a problem? Because the mortality is higher when you have a shock state and also different organs shutting down on you. Okay, and skin perfusion is another red flag. So they're going to be cold to the touch, but are they mottled? So modeling, so you can see here we get the modeling right there, versus modeling is a lot more spread out, versus modeling is way diffuse, much more diffuse compared to picture number 1 or stage 2. Right, so this is evidence-based. It's not like someone like just some old wives' tale. I look at the knees, and that's how I know if a patient's in shock. No, it's been validated by research and evidence-based things that you look at someone's knees, and if they have this diffuse modeling, that mortality is extremely high, right? Compared to someone who has just a little bit of modeling, that might be okay. It might be beneficial to add more pressors. But if someone has this diffuse modeling and they're on Levophed and vasopressin, just 2 pressors, adding a 3rd pressor is going to do nothing, right? The mortality is extremely high. And they probably need a goals of care discussion to discuss, how sick this patient might be. Okay, so we know cool hands and knees, but it's really this modeling is what kind of clues us in how sick they are and whether it's beneficial to add more vasopressors or not. All right, and then delirium. So we know delirium, especially with our toxic patients, like our patients who are who? Which shocks are toxic in appearance? Our septic shock patients, right? And especially new onset. So we have a cardiogenic shock patient who is mentating the whole time, and now all of a sudden this morning you come on shift and you had them yesterday, and now you have them, and now they are very confused. That's a problem, right? Of course you're going to see, are they hypoxic, something else going on? But if they're just a little bit shocky, I mean that means their shock state is getting worse or decompensating. Okay, and of course, especially in septic shock, right? That's one of the kind of clues we tell families is they have this change of mentation, right? If that's a sign that they probably should seek out help, especially if they have a fever and they have an infectious source like a pneumonia or UTI. Okay, again, cardiogenic shocks often have a normal LOC until they don't. All right. So labs and diagnostic tests. So what labs are going to do to figure out what kind of shock they have, right? So the labs you're going to do are going to be, potassium, right? Why is potassium important? Well, it tells me how good my kidneys are working, but also if my kidneys aren't working, my potassium keeps going up and up and up, that's going to do what to everything else? It can affect your heart. Now you have like a cardiogenic shock situation, right? Or Brady PEA situation. But also it's going to contribute to acidosis, right? We know your body doesn't like high potassium. It says, hey, I know how to fix that. I'm going to take that K positive, put it in the cell, and switch to another positive. The other positive being hydrogen positive, right? So the K goes in, the H comes out, and now we have this buildup of H. That's called what? That's called acidosis, right? And when you have acidosis, you're going to start compensating by retaining your what? Or not retaining, but you're going to start using up all your bicarb, right? Your bicarb will start going down and down and down, and we can see that on our regular chemistry, right? Our regular chemistry panel can tell you what your bicarb is, and what value is that? That's our CO2, right? Our CO2 on the chemistry will tell you that you have some acidosis brewing. It could be lactate buildup, or it could be an acid building up because of hyperkalemia, right? It could be the reason as well. So you see this CO2 is 9. That's not my CO2 breathing CO2. That's my dissolved carbonic acid. Okay, and then anion gap. We'll talk a lot more about anion gaps in renal, but anion gaps can start getting wider and wider and wider, and that can clue you in that you have an acidosis brewing. Is it lactic acid? Is it ketones? Is it potassium building up? That's what we're we're doing more labs and doing serial labs. What are serial labs? Do you test your Lucky Charms for sweetness? No, it's when you do labs, Q6 hours or Q4 hours, ABGs even, to see how low their pH is, right? CBC is like all shocks. Why would you want to do a CBC? What's the CBC going to tell you? It can tell you your platelet count. If you're using up platelets, why would you be using up platelets? A septic process. When you have sepsis, the inflammation stimulates the coag cascade, and you start making clots, and you start breaking them down. And yeah, you could be using platelets in that situation, but also you could think of a hemorrhagic shock, right? Hemorrhagic shock, you're going to be bleeding out everything: platelets, hemoglobin, and white blood cells, technically, right? And also the hemoglobin will tell you if someone that's bleeding in front of you, we want to track and trend it and make sure it's not getting worse, especially after you resuscitated them. Right, and WBCs can tell you if you have someone that has a sepsis process, right? You can look at the differential. You can look to see what are the neutrophils, right? So BEN, basophils, eosinophils, and neutrophils. Neutrophils tell you have what kind of infection, what kind of process. You have a infectious process, right? You have a bacterial process usually. Viral, it could be basophils, but usually it's neutrophils also. But what do eosinophils tell you? What's the E and the WC with the CBC with differential? It'll differentiate all the different white blood cells that are there, all the different platelets that are there. We look at the white blood cells. So we look at the eosinophils. We see that's elevated. That can tell you have what's going on. Not fungal, but anaphylaxis, right? So that clues you have an anaphylactic shock on your hands. All right, and then blood cultures. Obviously, this is kind of carrying into septic shock. UA will tell you if you have someone that's dehydrated. You can see if someone's dehydrated of the UA. You can see if someone has a DI situation, right? You can see if someone is peeing out all their water, all their free water. But more commonly, you can see if you have a bacteria growing down there. You can see your nitrates or leukocyte esterases are positive. And then sputum culture, that's going to tell us if we have sputum, we're going to test it to make sure that's not the source of our septic shock. And a CT chest, abdomen, pelvis can look for an infectious process, but it can also look for like an aorta that's dissecting. It can tell you if you have a like a tamponade situation developing. It can even look at RV strain, right? So the CT can give you good information. It can tell you if you have a pulmonary embolism as well. And EKG, it can tell you if you have RV strain over here, but also can tell you if you have a STEMI on your hands, because a STEMI is going to put you at risk for what kind of shock? Cardiogenic shock, right? And then we have a, the EKG can show you, again, this RV strain pattern. It's called an S1Q3T3. It's just, and you see an S1 in lead 1, you see an S wave, right? This deep S wave right there. And in lead 3, you see a T wave that's inverted and a Q wave prominent. That tells you might have RV strain patterns, right? You can also see that someone has chronic RV strain, like right ventricular hypertrophy or like cor pulmonale. But it can kind of clue you in that you might have something going on. What's really going to kind of seal the deal is getting a bedside ultrasound. So bedside ultrasound is called POCUS, or point of care ultrasound. So you do a little hocus pocus, and you're going to look at the lungs. You can look at the heart. At the heart, you can see if they have a tamponade developing. You can see if the RV has strain, right? You can see that the RV is super, super dilated because it can't pump the blood forward because there's a huge PE in the way, for instance, right? You can see there's different protocols out there, but basically you look at the heart, you look at the lungs, and then they can look at the aorta too. They can look at the bladder to see if there's any urine in the bladder. So these are all things to assess, is the pump working, right? You look at the heart and you see if there's a good ejection fraction. We can get a rough estimate of how it's doing. We can see if there's aortic stenosis developing, right? For like what kind of shock is aortic stenosis? It's an obstructive shock technically, but sometimes we clue it into with a cardiogenic. We can see if there's a tank problem. We can look to see if they have fluid building up in different areas, or if they have, what's called the inferior vena cava diameter. You can see like IVC is super, super dehydrated or narrowed. That might clue you in. You might have a low volume status because there's not a lot of volume returning to the heart. Well, that could also be distributive shock, right? So that's why looking at the pipes can tell you as well. There's an obstruction in the way, that's obstructive shock, or they can see if you are very, very dilated, but also looking at the other parts of the picture. Is the white count elevated? Is there, how bad is lactic acidosis, right? What does the CT tell us? What does the, the UA tell us? Okay, so again, hypovolemic shock, distributive shock, what's the CVP here? Well, that's going to be very, very low because we're not returning fluid back to the heart for two reasons. Either we're vasodilated or we don't have a lot of volume circulating. So how do you differentiate them? That's where they would look to see, do they have what's the ejection fraction? We know early sepsis might have an elevated ejection fraction because it's really making the heart work extra hard. But also we're looking at the kind of the appearance of the patient, right? Obviously we see like a history of nausea, vomiting, diarrhea, or bleeding. That's hypovolemic. Or if you see a patient that is, has warmer extremities, has this, then that can lead to cool extremities later. But have this fever, definitely is not going to be hypovolemic shock, right? Well, shoot, what if they have C. diff infection? Now they have a fever. It's like, well, now you have that's like a more complicated shock process, right? So yes, it can get hairy, but the idea is if it's like it's cut and dry, they got a fever. Usually we're thinking we're on the side of which kind of shock? It's a septic shock, right? And RV failure, LV failure, these are all cardiogenic we've been talking about, right? Your RV failure, you got a PE in the way, you have someone with really bad pulmonary hypertension, right? As an outpatient, obese patient, or pulmonary fibrosis patient. And then LV failure, that's a little more common, not as deadly as an RV failure, but LV failure could be due to a what? Why would my left ventricle fail? Do an MI, and how would we know you have an MI? Do an EKG, right? An echo can tell you as well. The echo at the bedside, you can see that there's wall motion abnormality happening, right? So these are the ideas behind, looking at all the pieces we've been looking together as far as, what are the hemodynamics and what are the symptoms that might develop in different shock states. So our shock labs. So in the previous slide, we kind of talked about some labs and introduction, especially some red flags. But what are some of the labs that might pop up? You got a lactate. Obviously, we have no flow to the tissues, right? They don't care that there's no there's not as a low flow. They just care they're not getting oxygen. So yes, low oxygen can cause hypoxia and cause lactic acid production, but basically it's a lack of flow to the kidneys, right? The cardiac output is poor, right? So your arterial oxygen, your PaO2 can be poor, right? Your cardiac output is what we're kind of thinking about right now, right? Why is the cardiac output low? Like, it could be stroke volume or heart rate. Heart rate's low, fix the heart rate, right? Stroke volume is low, it could be contractility, cardiogenic shock. It could be preload, which is, septic shock or distributed shocks and your hypovolemic shocks, right? This is kind of where we're talking about the shock piece right here. And then we have the hemoglobin itself, right? Low hemoglobin, yes, happens with hemorrhagic shock, but someone can develop anemia over time, and now they have low O2 delivery to the tissues, and of course that will raise lactate. But really, today we're really focusing on the cardiac output piece. But this is your DO2, right? Your delivery of oxygen. Your delivery of oxygen is the cardiac output, your PO2, your oxygen saturation, all these things are what contribute to O2 delivery to the tissues. And when the O2 delivery in the tissues is increased, like in sepsis or in fever or in shivering or seizures, all that's gonna, we've got to make sure the DO2 is keeping up, the train is keeping up with the O2 delivery, otherwise lactate is gonna start going up, right? When someone has seizure activity, lactate goes up because for this same reason. Okay, so many things cause rise in lactates, right? It can actually be a little bit beneficial up to a point, and usually that point is 4, right? So usually when you're greater than 4, it's no longer beneficial. It's no longer a eustress, it's a stress, right? Someone like it's the first thing I tell you in first semester of nursing school. It's like you get good stress is good stress, right? But there's a certain point where it's not great, right? So anyways, they used to have this central venous oxygen saturation, like follow the SCVO2, and that's your golden ticket. That's what's going to get you out of this, right? Keep the SCVO2 greater than 75%, and you're going to improve your outcomes. But little do you know that the guy had stock in the same company that sold the SCVO2 monitors, and also he was, the research he did was flawed. Like he was laying, she was, laying the cards in his favor. So, it was bad research basically, right? It wasn't double-blinded, it wasn't randomized. It was his trial, his things. So he made thousands upon thousands of dollars, and a lot of patients died because of it. So yeah, so he was like, oh, raise the SCVO2 and you'll have great outcomes. We know this is like 60 to 80%, right? That's what a normal venous oxygen is, and whatever comes in to the tissues and whatever gets used is your VO2. But when you have like septic shock, for instance, your tissues, mitochondria don't work, and therefore the VO2 might be a little elevated in the meantime. Or if your cardiac output is increased, right, it's going to bypass tissues altogether, and your SCVO2 can be up. But what if your hemoglobin's low? It's like, well, we didn't factor that in. Don't worry about that. It's like that's what DO2 is. What are you talking about? What if your PO2 is super high? What if they have hyperoxia? Right? They got 600 PO2s. Oh, don't worry about that. It's like, well, those are different variables they have to worry about. No, it's like, no, you don't worry about it. You buy my catheter, right? So there's all kinds of things that can affect it, right? Your temperature can affect how much oxygen utilization you have, or your O2 hemoglobin dissociation. That's a horrible curve. Your O2 hemoglobin dissociation curve, right? It shifts left and shifts to the right based on different situations, right? Just measuring SCVO2 is not going to tell you, that you have good outcomes or not, right? So it was a thought, but it doesn't work, right? And this kind of validates all the different variables that we can change. We can change the cardiac output. You can adjust the values to get a great SCVO2. See, SCVO2 is 60, 9%, 75%, but all we've done is change the variables around, and you can get a change in your SCVO2. All right, so we can see that SCVO2 is a no, right? Increasing the hemoglobin or hematocrit to greater than 30%. It was one of the recommendations. That's obviously not great because you're gonna have more risk for blood transfusion reactions. And then there's, getting the CVP really, really high to improve the forward flow through the tissues, I guess, was kind of the rationale. And that would, worsen people's fluid overload state, and that's going to cause more problems, right? Especially someone who is cardiogenic, right? Cardiogenic shock, they already have an increase in CVP, right? That's not going to be a great thing to add on top of it, right? And it's kind of where the saving sepsis guidelines had like the 30 mLs per kilo. It all derived from this poor evidence as well. And the evidence has gone worse and worse over time. Like the recommendation for fluid resuscitation, it used to be like, oh yeah, go for it. And the other one is like, yeah, if you could. And it's like down to like the lowest rating as far as evidence, as far as fluid resuscitation is concerned, right? Because they're realizing this evidence was poor in this regard, right? It used to be really pushed by the Edwards company, right? So, monitor SCVO2. Our CVP's lines, our triple lumen catheters had SCVO2 monitored on it, but it's not validated evidence, not evidence-based. All right, so symptoms of shocks, and again, we're still talking about all shocks kind of now. So we're kind of mixing and matching, kind of pointing out where the differences are, and then we'll focus in on cardiogenic shock versus septic shock versus hypovolemic shock specifically. But coming back to this, looping back around, you kind of see how when someone comes, you really don't know officially what they have, right? You don't know if it was just a pneumonia, right, or the pneumonia was the trigger for their heart failure, right? So now they have two things going on, right? So no single test for etiology. You can't say, I'm going to do this test and we're going to find exactly what kind of shock you have. It's really like 3 to 4 tests we're looking at. Obviously, they have a huge STEMI and they're hypotensive. Like I could probably think it might be cardiogenic, right? Or they come in with a trauma and they got like a cervical spine injury. They might have neurogenic shock, right? As long as there's no other bleeding going on, right? So we got to put a lot of pieces of the puzzle together. So shock is a little bit, what's the word? Nebulous, right? So that it's not exactly clear on what it is, right? All right, so history. So look at the history is a big piece. Oh, you got an EF of 10%. That might be a reason why we might be at risk for cardiogenic shock. But they also have a pneumonia or they have a UTI. You can just, not every UTI puts you into CHF exacerbation and cardiogenic shock, but we got to keep it on the back burner as a possibility, right? EKG, echo we talked about, CT scan looking for any kind of source of infection, but also looking for, if it's with contrast, you're looking for what? A CT scan with contrast can tell you if you have. It can tell you if you have a PE, right? It can tell you if your aorta is dissecting. It can tell you if you have a bleeder, right? Like a mesenteric artery, you can see that it's oozing blood. So you can see all these things. So CT scan is really has a lot of utility. Okay. And then, what is it, adrenal? So they got adrenal issues. They're on steroids at home. That's going to clue you in that we probably need to presume steroids. That's one of the patients, if we have a patient with shock, right, someone with steroid use at home can have pneumonias, right? It puts them at risk for infections, right? So we want to be able to capture that. And then VTE, right? So do they have a swollen extremity, right? That's red to the touch and is very painful. That might be a risk factor for a PE, right? Obstructive shock. And what are other sepsis risk factors? They're immunocompromised, again on steroids. They got invasive devices. They came in with a PICC line and a Foley catheter placed in their last hospital stay 30 days ago. That might be a source of infection, right? Or the PICC line might be a source of infection. So we look for those kind of things, right? They have a nephrostomy tube in place, right? Because they have a lot of stones. It was for diversion, or maybe they had cancer. Now they're immunocompromised, and now they have a device in place. All these things put you at risk for more sepsis, right? Recent procedures is important, right? They have a recent hip surgery. That could be hemorrhage, or it could be due to an infection that's developing, right? They have a debridement. Well, that could clue you in. They probably debrided out something nasty, right? Some necrotic tissue. That could be the source of infection as well. Okay, and then trauma. Do they have any history of having a traumatic event of some sort? Oh, I fell down the ladder 3 days ago, and then today I started feeling confused. It's like, well, maybe it might be a head injury with a head bleed, right? But that wouldn't cause shock. But maybe they have like a retroperitoneal shock where they have some cracked ribs causing hemothorax, right? So all these things we're kind of putting together based on their history, right? And then current meds, like I mentioned, steroids, but what if they're on like clonidine, for instance? Clonidine usually causes rebound hypertension, but let's say, what's another example, right? A little different changes in their medications. So they are on clonidine, but now they're 0.1, now they're on clonidine 0.3. Right, they just got to order the doctor's office on Monday, and now it's Wednesday, and they've been religiously taking their medications, and now they're hypotensive because they took too much clonidine, right? And then your SNS will fire off to try to fix any kind of drop in your blood pressure, right? Any kind of hypoperfusion, your SNS will try to fire off and try to fix the issue, right? So you got a low blood pressure up here, your baroreceptors that are sitting in your aortic arch, right, in your carotid bodies right there. They're sitting up there, they're checking at all times what the blood pressure is. If the blood pressure is too high, they're going to slow it down. Whoa, that's too much, just slow down the SNS activity. But if there's not a lot of blood pressure, it's going to start firing off the SNS is like nobody's business, and it's going to start trying to raise the blood pressure, raise the heart rate, right? Heart rate's going to start trying to go up, but the blood pressure, usually it can't fix. That's usually why they present to the hospital. Right, so vasomotor centers, so that's in your medulla, and it's going to send out the SNS signal to try to, increase the vasomotor tone, right? Vasoconstrict as much as possible. And that electrical activity can't last for very long, so it's going to start secreting hormones to do its work, right? One of the hormones being epinephrine, right? Norepinephrine is usually at the terminals. Epinephrine is usually in higher amounts of the bloodstream when you have an SNS response, right? That's why after you nearly get in a car accident, you pull over the side of the road, you're still shaking, still trembling, still have a feeling of impending doom, right? It's because the epinephrine is washed through your body. Or after you just asked your future novia out, right? Then you're like, well, then you're afterwards, you still have the nerves, right? So it's the same situation. Okay, and then what else? So it's going to squeeze some blood a little bit. It's going to work on not only the arterial side, but it's also going to squeeze some blood into the right atrium, hopefully, to kind of and raise our blood pressure, because that's what's going on, right? So what else happens? So we know that's to maintain the response, we can release the norepi and epi, but we can also have other hormones that will vasoconstrict. So we're going to loop back around, we're going to circle back, corporate speak, right? We're going to circle back and we're going to trigger the renin system to fire off, right? Little beta-1 receptors on our glomeruli, right? At the JG complex and our glomerulus, right? So those are going to be activated, and now the renin, angiotensin, aldosterone system fires off, right? So we've got the RAS system firing off, and it's going to do its thing. It's going to release angiotensin 2, right? Angiotensin, tenses angios. It's going to vasoconstrict and raise the blood pressure. And angiotensin 2 also triggers aldosterone. Aldosterone is going to raise blood pressure because it's going to reabsorb more sodium. And where sodium goes, water follows. So that's going to restore some blood volume, right? And then just for giggles, we're going to also trigger ADH, right? Which gets stimulated by angiotensin 2, and also gets stimulated with the SNS. So now we got 3 things to vasoconstrict and raise our blood pressure, right? And that's kind of our goals. And then we talk about all this stuff because next lecture we talk about IV titrations and pressors. And you have vasopressin. Again, remember ADH is under witness protection, right? So you have vasopressin, which is also ADH, it's also DDAVP, also LDA-arginine vasopressin, right? So it has all kinds of different names, but it's vasopressin, right? And we got norepinephrine as one of our drips, or Levophed. We got epinephrine as one of our drips, right? There's a drip called angiotensin 2 as well, right? It's really expensive. Our pharmacy doesn't approve it because it's too expensive. We got a new pharmacy director, so we gotta coax him and let us order angiotensin 2, right? So we have all kinds of different medications that we are going to interact with this system to maintain this vasoconstrictive process, to restore blood pressure, restore MAP. All right, so again, comparing our different shocks here, right? So anaphylactic shock, is that distributive, or what's going on in anaphylactic? Why are you shocky? Why are you low blood pressure?
Well, it's still like an immune response.
Good, it's an immune response. Specifically, it's a histamine response, because technically septic shock is an immune response also. So you have the excess of histamine, you might get some bronchoconstriction. Histamine also causes rashes, right? Causes urticaria, and that's just itchy rashes, right? And hives. So those things can develop. But as you notice, all shocks have low blood pressure, right? There's no shock that has high blood pressure, but there is shock that has low heart rate and not high heart rate, because every shock has high heart rate except for which one? Right, so you see all of them have high heart rate except for our neurogenic shock, right? This is kind of comparing all of our shocks at a glance, right? And then cardiogenic, right? It's going to definitely have a low blood pressure eventually, right? At first they're trying to mentate. They might, be compensating with this whole system up top with the RAS, the angiotensin 2, the vasopressin, sympathetic nervous system. But eventually it's going to fail, and your blood pressure will be low. And then we can throw in a PA catheter, and we can measure that they have elevated pressures in the chest because the blood's not going forward. They're going to have symptoms of pulmonary edema, right? You don't get pulmonary edema symptoms with septic shock, right? Unless the septic shock causes cardiogenic shock. But no, we're going to try to kind of keep our borders lined up. But in real life, you do have shocks that are what are called undifferentiated, where there's multiple things that can be at play. Okay, looking at pulse pressure can give you good information, right? Which shocks have wide pulse pressures? Septic shock for sure, right? Any kind of vasodilatory shock technically, right? Neurogenic, our anaphylactic, and our septic shock all have wide pulse pressures because the diastolic is going to be very, very low, right? And diastolic is a function of afterload, right? So our systolic, yeah, might be a little bit low because we're not returning a lot of fluid, but we're definitely vasodilating and definitely widening that thing out. Compared to like cardiogenic shock, right? Your heart's not pumping blood out, right? Cardiogenic shock, you're not pumping blood out, therefore SNS is going to fire off. So what the heck? Where's my blood pressure at? And it's going to fire off this whole neurohormonal cascade and try to raise the diastolic blood pressure, right? So systolic's a little bit poor, right? And diastolic's super high. So that's a narrowing of my pulse pressure, right? And then same thing with hypovolemic shock. That also has a narrow pulse pressure because I can't put a lot of systolic blood pressure out because I have no volume to give. My preload is poor, right? The preload is very poor in hypovolemic shock. It's also, you could say it's poor in cardiogenic shock, but really it's increased, right? It's not putting any blood out. The blood's being delivered to the heart, but in hypovolemic shock, but it's not able to put out an effective amount because it's not getting a lot in the first place. All of it is being bleeding out somewhere, or all of it has been diuresed out, or pooped out, or vomited out, right? So there's less volume inside the heart to begin with. And therefore it's a low systolic pressure. And what is the SNS thing? Where's my pressure at? And it's going to start squeezing down. You're going to have a narrow pulse pressure, right? In a hypovolemic shock. We're not putting a lot of preload out, right? You're not putting a lot of stroke volume out. Okay, so that's the idea behind looking at different elements, different things to kind of piece the puzzle together to figure out what kind of shock they have, right? Looking at ultrasound can help you. Looking at the monitor, just looking at the pulse pressure, oh, you got a little hypovolemic, aren't you? Let's give some fluids. It might help, right? But if someone's super vasodilated, you can give like 2 liters of fluids maybe initially, but giving another 500, another 1 liter is not going to do much. It might cause harm, if anything. Okay. And then we'll talk about hypovolemic shock, but there's different levels of it, 1, 2, 3, and 4. You can think of it like tennis, right? You got one point in tennis. It's not 1-0, right? What is it? It's 15. It's like, how'd you get 15 points already? I scored 1 point against you. That's how it happened, right? So yeah, 15%, right, loss of blood volume versus 30% loss versus 40% loss. And usually stage 4 shocks is usually game, right? Usually mortality is incredibly high when you have more than 30% blood loss. Okay, so this is your overview of your shock symptoms. Now, overview of our shock treatments, right? Our goal is, again, once identified, you've got to try to figure out what kind of shock it is so we know what to do. We'll give volume resuscitation if it's appropriate, right? So septic shock is appropriate, hypovolemic shock is appropriate. I mean, the cardiogenic shock, you might get away with 500 cc's, 1 liter at the most, but that might cause a lot more problems than good, right? Because they already have great preload. They just can't get rid of it, right? Whereas hypovolemic shock, they don't have good preload, and the preload they push out, or the stroke volume they push out, is poor, just like cardiogenic shock. They have poor stroke volumes, but there's different etiologies, right? And having a little bedside ultrasound can help, right? To figure out what kind of shock it is, right? You can see the ventricles very, very close together. It's like, well, shoot, they're dehydrated, right? Or they are hyperdynamic in septic shock. But if they are super dilated, it's like, well, that might be a cardiogenic reason, right? Or even like an obstructive reason. Okay. If fluids fix the problem, though, it might temporarily raise the blood pressure, but if it's really helping, it probably is a hypovolemic situation. And then if fluids don't work, usually they always say fill the tank first before you put the squeeze on. But that's up to a certain point. So in the ICU, we have to be cautious because we can cause other problems. We can induce acute kidney injuries. We can cause them to go into pulmonary edema and require to be intubated when they weren't intubated before. So vasopressors, again, MAP starts dropping less than 65. We tried the fluids, but now we need to be giving vasopressors to raise the blood pressure. Antibiotics, especially for, of course, septic shock, it's not going to do anything for anaphylactic, it's not going to do anything for neurogenic, it's not going to help cardiogenic, it's not going to help hypovolemic, right? The goal is only for septic shock and identifying it quickly, okay? And again, if cultures are done before antibiotics, so we know exactly what antibiotic to give, because antibiotics themselves can cause acute kidney injury, can cause liver damage. So we want to make sure we have the right antibiotics on board. And steroids are great. They have a lot of benefit, especially during chronic steroid use. We know we want to resume that, but just steroids in general. So septic shock patients, it makes sense because their immune system is out of whack and it's too inflammatory. So we're going to give some anti-inflammatory steroids to kind of calmate, right? Tranquilo, it's okay, right? No, stop it, right? So that's a little easier to say calmate, right? So you said stop it, right? So that's steroids do have side effects, but you can see in septic shock, they have a lot of benefit, and the benefit outweighs the side effects when you give them in septic shock. specifically. And it's actually part of the European guidelines, and the American guidelines haven't adopted it just yet. And post-ROSC, we mentioned before in cardiac that, in ROSC situation, that's a surge response. So it makes sense. We have a surge response, we give some steroids, right? So you got cardiogenic shock here. We got our distributive shocks, like our vasodilatory shocks, hypovolemic shocks, and our obstructive shocks. These are all the things we're going to try to fix and figure out what the reason was previously, but now we're going to try to fix it with fluids if it's appropriate. If it's pressors, obviously probably going to go to pressors at some point if they're in severe shock, but kind of fixing the underlying problem, right? Getting IV access, getting your vital signs, can tell you about your pulse pressure, is there something readily reversible? Do they have a cardiogenic shock or an obstructive shock because of tamponade? We can fix it right away with a pericardiocentesis. If they have a PE, we can fix it right away with a thrombolytic, for instance, right? And then you stabilize it, right? Make sure their airway's intact, they're breathing okay, because if cardiogenic shock, they could be all this pulmonary edema, right? And then what else? They have access to give fluids if we need to give fluids, right? So all the different labs, we can do all whole rainbow labs, CBC, coags. You're doing your basic metabolic panel, probably a comprehensive metabolic panel at first, and then you might trend your basic metabolic panel. And we're going to kind of figure out what is going on, okay? And then we got to stabilize at the end, right? We can't just keep doing what we're doing, keep giving fluids, because as we'll find out, fluid overload is just as bad as on the flip side, right? In the ER, when you're resuscitating, that's great, right? That's this resuscitation phase right here. You're resuscitating the fluid balance, but by day 3, day 4, we want to get the fluid balance actually even, right? Otherwise, it's going to start causing a lot of problems body-wide, right? It's going to start overloading the body, start causing, abdominal compartment syndrome, start causing fluid congestion in the kidneys, causing acute kidney injury. So it has a lot of consequences if we have too much fluid on board. Okay, so steroids have a lot of great use and utility here, and giving fluid resuscitation to a certain point is good, and then find out what the underlying cause is so we can fix it. If it's sepsis, let's give antibiotics, right? If they forgot their steroids at home, then let's give steroids, right? If they have like an adrenal situation brewing, okay? So that's the idea behind undifferentiated shocks. We don't know what it is, but we're going to try to do all the tests and find the right treatment that might fit the puzzle.